As we all know that most of the expansion appliances have screws that are incorporated, and these are the components that are required for the expansion of the jaw. So what does an expansion screw have? It consists of an oblong body that is divided into two halves, the right half and the left halves, and each half they have an inner threaded side that receives one end of the double-ended screw. So in this figure we can see this is oblong body screw, and it can be divided into two halves, the right half and the left half, and then each half at the center you can see these are the lead screws. These are the one side end of the double-ended screw. Now the screw also has a central bossing with 4 holes. So this numbered 1 has 4 holes in it, and each holes, when they are turned, they rotate by 90 degree. So there are a total of 4 holes for 360-degree turns, and these holes receive a key to turn the screws. Now 90-degree turn brings about a linear movement of 0.18 millimeter or nearly 0.2 millimeter. So if you rotate these screw, the holes by the key by 90-degree rotations, the linear displacement would be 0.18 millimeter. So a complete turn, that is 360-degree turn, would bring about a linear displacement of 0.8 millimeter, meaning that the jaw would expand by 0.8 millimeter. So these are the parts. The 1 is the perforated cylinder that has 4 holes, 2 is the lead screws, 3 represents the guide pins, and 4 is the platform in which all these components are incorporated. So this was about the expansion screw. Now what is the activation schedule for the rapid maxillary expansion? For rapid maxillary expansion there are two activation schedules given. One is given by TIMS and the other is given by Zemring and Isaacson. So according to TIMS, for individuals who are up to 15 years of age, that is below 15 years of age, who are still undergoing age, for those individuals 90-degree rotations is given in the morning and the evening, that is 2 rotations per day. And for individuals who are 15 years of age or over 15 years of age, 45-degree activation is required 4 times a day. Now the schedule given by Zimring and Isaacson, in young growing patients, they recommend 2 turns each day for 4 to 5 days. That is 90-degree turns 2 times a day for first 4 to 5 days, and after the first 4 to 5 days, 190-degree turn, that is 1 turn per day till the desired expansion is achieved. Now in case of the non-growing adult patients, they have recommended 2 turns each day, that is 90-degree turns for first 2 days only, which is then followed by 1 turn per day for 5 to 7 days, and then 1 turn every alternate days until desired expansion is achieved. So this was about the activation schedule. Now treatment evaluations during rapid maxillary expansion. How do we evaluate the treatment during rapid maxillary expansion? How do we know the rapid maxillary expansion appliance is actually working? Clinically, the most noticeable feature during rapid maxillary expansion is the appearance of midline diastema, which is the space between the 2 central incisors. Now the distance of the spacing is about half that of the displacement produced by the screws. So this also gives rough idea about the amount of expansion, but this midline diastema is not a reliable factor. It is not considered a reliable factor for estimating the amount of expansion. Rather, maxillary occlusal radiographs or the posterior anterior cephalograms are more reliable than the midline diastema. So the midline diastema only needs to visualize clinically, whereas for estimating the amount of expansion, the maxillary occlusal radiograph and posterior anterior cephalograms is preferred. Now, when do we not use rapid maxillary expansion? As we have already gone with the indications of the rapid maxillary expansion, these rapid maxillary expansion are not indicated in single tooth crossbites. If a single tooth is in crossbite, rapid maxillary expansion is not indicated because rapid maxillary expansion brings about the expansion of whole arch. So these are not indicated. And also in uncooperative patients, because there is no use of giving rapid maxillary expansion if patient does not cooperate, that is if the patient does not activate the appliance. And also we knew that rapid maxillary expansion is given in individuals of growing age before they have ossified the mid-palatal suture. So these are contraindicated in cases of the patient with ossified mid-palatal sutures. Also, if the patient has asymmetrical maxilla as well as mandible, and also adult cases with severe anterior-posterior discrepancies, these are contraindicated. Now these rapid maxillary expansion, as we have already discussed, it brings about steep mandibular plane, so it increases the vertical height of the face. So these are not indicated in vertical growers with steep mandibular plane, and also these are contraindicated in periodontally weak dentitions, as these anchor tooth are exert pressures on the periodontium, that is periodontal membrane compression is there. So on periodontally weak dentitions, these are contraindicated. So this was about the contraindications. Now retention following rapid maxillary expansion. So after rapid maxillary expansion has been given, there is high tendency of relapsing. Now most authors recommend a retention period that is of not less than 3 to 6 months. And for these retentions, we can either use the same rapid maxillary appliances, or we can use either removable or fixed retainers like transpalatals. Now if we are to use rapid maxillary expansion appliance itself for the purpose of retention, the screw in the rapid maxillary appliance should be immobilized using cold cure acrylic so that further expansion is not produced. Now surgery as an adjunct. We knew that rapid maxillary expansion was carried out in individuals of growing age in which the mid-palatal suture has not been ossified, but this can also be conducted in individuals, in the mature individuals in which there is already ossifications of the mid-palatal sutures. So how do we perform that? It requires surgery as an adjunct. So these are indicated in palatine bones which exhibit unusual resistance to separations. So these resistance occurs in female patients over 16 years of age and in male patients over 18 years of age in whom the mid-palatal sutures has already been ossified. Now there are four areas of resistance. In the anterior region, the area of resistance is formed by the pyriform aperture pillars, whereas in lateral aspect, zygomatic buttresses forms the lateral resistance, and pterygoid junctions forms the posterior resistance, whereas mid-palatal synostosed sutures forms the medial resistance. Now, what do we do in cases of those individuals? We use a technique called as surgically assisted rapid palatal expansion, SARPE, which involves surgical separation of these attachments, thereby allowing expansions to be easily achieved using conventional rapid maxillary expansion. So in these cases where rapid maxillary appliance alone could not separate the mid-palatal sutures, what we do is we give a surgical incision or surgical cut in the area of resistance that prevents the separation, so that the mid-palatal sutures can be split, and then this is followed by the conventional rapid maxillary expansion appliances. Now for these surgically assisted palatal expansion, it may be required to move apart the roots of the maxillary central incisors before surgery, because the roots of the maxillary central incisors may be damaged while giving midline maxillary cuts, so they have to be moved apart before surgery is performed, which can be done using fixed orthodontic appliances prior to the surgical expansion. Now, expansion in this case is typically carried out at the rate of 0.5 millimeter per day, which is almost same for all the rapid maxillary expansion. But however, this surgically obtained expansion has a greater relapse tendency because of inelasticity of the palatal mucoperiosteum, and a degree of overcorrection is valuable. So we have to overcorrect to neutralize the relapse tendency of the surgical assisted rapid palatal expansion, it is SARPE. Now, clinical tips for rapid maxillary expansion. What are the tips that has to be given to the patient? We have to instruct patients to maintain proper oral hygiene using rapid maxillary expansion appliances, and also orthodontic movement of the anchor teeth should be avoided prior to the rapid maxillary expansion. And the patient should be trained to use the key so that the patient can use the key properly and efficiently. Similarly, maxillary occlusal radiographs should be taken at regular intervals to monitor the expansion, how much expansion has taken over a different follow-up period of time. So other than that, the possible immediate effects of the premature appliance removal, which includes dizziness, pressure at the bridge of the nose, pressure under the eyes, blanching of the soft tissues under the eyes, they have to be informed to the patient, and therefore care should be taken to avoid the premature appliance removal. Now the next method of expansion is the slow expansion. Here, as the name suggests, the expansion occurs at a rate of 0.5 to 1 millimeter per week. It was about 0.5 to 1 millimeter per day in cases of the rapid maxillary expansion. For slow expansion, 0.5 to 1 millimeter per week. So as this is slow expansion, it is more physiological, and so more stable result is produced. Here the forces generated are also much lower, that is only about 2 to 4 pounds, whereas in rapid maxillary expansion it was about 10 to 20 pounds. During rapid maxillary treatment, the treatment would complete in 1 to 2 weeks, whereas in slow expansion it takes more than 2 to 5 months. And in slow expansion, this skeletal expansion is not produced, or it is produced insignificantly. The main expansion is due to the dentoalveolar movement, so this is also termed as dentoalveolar expansion. Now, what are the advantages of this slow expansion? Why do we need to use slow expansion when we have rapid maxillary expansion? The advantages would be because the slow expansion method is more physiological, so it is associated with more physiologic adjustment to the maxillary expansion that brings greater stability, and it also has less chance to relapse as compared to rapid maxillary expansion. And there is less dental tripping, less sutural traumas unlike rapid maxillary expansion. And also in cases of the rapid maxillary expansion, we would expect a large diastema appearing, which would never appear in case of the slow expansion. So these are the reasons why we use slow expansion. Now, what are the appliances that can be used for slow expansion? There are different appliances that can be used for slow expansion. So some of them are removable appliances incorporating jack screws. It could be coffin spring, W arch appliance, quad helix, or even fixed appliances can be used. In fixed appliances, expansion can be carried out with arch wires that is used in fixed appliances, or quad helix can be used along with fixed appliances, or auxiliary arch wires can be used along with the main arch wires in fixed appliances. Now for the first part, that is the removable appliances incorporating jack screws. As the name suggests, these are removable appliances, meaning that it can be removed by the patients and it incorporates jack screw. Jack screw is responsible for bringing about the expansion. Now, how expansion is produced here is that expansion is produced predominantly by tipping the molar teeth buccally. So this is, as we all know, so expansion is dentoalveolar expansion. Here the expansion is produced by buccal tipping of the molar teeth. The base plate of the appliance is sectioned in the middle so that there is an equal number of anchor molars on both the sides in midline, producing bilateral symmetrical expansion. So as we can see in this second picture, the acrylic plate is split in the middle so that it is bilaterally symmetrical and also brings about bilaterally symmetrical expansion. So the component present in the middle is the jack screw. Now retention of the appliance is achieved using Adams clasp on the first premolars and the first molar, or we can use bands in case of first premolar and the first molar, or simply we can use Adams clasp. By splitting the base plate in the middle, symmetrical expansion is produced. However, removable appliances incorporating jack screws can also be used to produce asymmetric expansion. So if asymmetric expansion is desired, it can be used by sectioning the base plate so that more teeth are in contact with non-expanding side. So in this first figure, it produces asymmetric expansion. These larger areas provides as a support, whereas the force is exerted on these tooth, which brings about the expansion on only this area. So it also can bring differential expansion depending upon where the base plate is sectioned. Now, what are the advantages of using removable appliances with jack screws? As with every removable appliances, the main advantage is that it can be removed for cleaning. The patient can clean the appliances and maintain oral hygiene properly. It also has an ability to have an additional active components like judge springs, finger springs for additional tooth movement. Now the disadvantages, as with any removable appliances, it needs patient cooperation. Since the patient can remove themselves, patient cooperation is not so much achieved using removable appliances, and also they have the difficulty to obtain adequate retention in the mixed dentition period, where some of the teeth are not yet erupted and some of the teeth are erupting. So this was about removable appliances incorporating jack screws. Now for coffin spring, it is named coffin spring because it was designed by Walter Coffin. It consists of an omega shaped wire of 1.25 millimeter. So you can see here it is an omega shaped wire which is made up of larger diameter wire that is about 1.2 millimeter thickness, which is placed in the palatal regions. Now the free ends on either side of the omega wire, these are embedded in the acrylic plate, as you can see in the figure, covering the slopes of the plate. Now activation can be done both extraorally or intraorally. For extraorally, the appliance can be removed and the two sides can be separated manually, and then it can be placed in the oral cavity, or three-prong pliers can also be used to bring about the activations. In these regions, the three-prong pliers can be used to squeeze the wire so that the free ends move wide apart, bringing activations of the coffin spring. Now for W arch, it is called W arch because of the configurations of the appliance. That is, it is W shaped, so it is called as a W arch. Here it uses only 0.36 millimeter stainless steel wire for expansion. The wire is of smaller diameter than compared to coffin spring, and these W-shaped wire is soldered on the first molar. As you can see in the figure, on either side the wire is soldered onto the first molar, which is banded. Now it extends from the first molar posteriorly up to the canine in the anterior region on both the side, and it is not kept in contact with the palate in order to avoid trauma and irritations to the palate. And how do we activate this? Now activation is done by expanding the appliance by 4 to 6 mm prior to insertion. So before inserting, the appliance is expanded by 4 to 6 mm. For anterior expansion, free arms is expanded, whereas for posterior expansion, the anterior part of the arch is expanded. This was about the W arch. Now moving on to the next appliance, that is the quad helix. It was described by Ricketts. It is called quad helix because there are 4 helices, 2 anterior helices and 2 posterior helices. It is constructed using 0.038 inch wire, which is soldered to the bands on the first molars. As I have already told you, it consists of a pair of the anterior helices and a pair of the posterior helices. So in this figure you can see 2 anterior helices and 2 posterior helices, and the metal wire between the 2 anterior helices is called as the anterior breeze, whereas the helix between the anterior and the posterior helix is called as a palatal breeze, and the free ends on both the side are termed as an outer arms. As you can see in the figure, it is soldered into the banded first molar. Now it can be used to expand the narrow arch as well as to bring about the rotation of molars. So how do we activate it? It is either pre-activated by stretching the 2 molar bands apart from each other before insertion, and then this is cemented, or by using 3-prong plier as shown in the figure after cementation. So after cementation has been done in the first molar, 3-prong pliers can be used to squeeze the anterior breeze, which brings about the expansion in the posterior side. Now why do we use quad helix? What are the advantages? Patient compliance is not required as it is fixed appliances because the molar band is cemented onto the tooth. It is also used in conjunction with the fixed appliances. It also has good retention as it is soldered onto the bands that are cemented on the molars, and it can produce limited skeletal expansion when used in young individuals apart from the dentoalveolar expansion. And also it is inexpensive to fabricate because it is simply made up of a wire. It has got larger range of actions. It not only brings the symmetrical expansion, but also it brings the differential expansion of anterior and posterior segment, and molar rotations as well as torque is also possible. So multiple type of the movements is also possible with quad helix. It can have limited role as a habit breaker, so it can also be used as a habit breaker appliances. Now for the disadvantages of the quad helix, it brings mostly the dental expansion. As we all know about these two expansion appliances, all of these bring mainly the dental expansions. They only have limited skeletal expansion or no skeletal expansion, and also which causes molars to tip buccally, and that can result into the open bite. Now using fixed appliances, arch expansion can be achieved in patients who are undergoing fixed mechanotherapies. So what are the methods? Expansion with arch wires, use of quad helix as we have already discussed this, and use of auxiliary arches. First is the expansion with arch wires. Now mild expansions can be brought using expanded arch wires, which is made up of a larger dimension stainless steel wire that can bring about significant expansion. For expansion using arch wires, the arch wires should be wider than the dental arch by at least 10 to 12 mm. The main advantage of using rectangular arch wire is that it maintains torque during expansion. So if these inner line represents the ideal arch form, then we have to select a arch wire which is wider than this ideal ovoid arch form by at least 10 to 12 mm so that it can bring about expansion. That is, it has to be wider than that of the dental arch to bring the expansion. Now using quad helix, we have already discussed this. That is, the quad helix can be incorporated along with fixed mechanotherapies. Now expansion using auxiliary arches. Here the expansion arch is made up of rectangular stainless steel wire or larger round stainless steel wire of diameter 1 to 1.13 mm, and auxiliary arch wire, they run over the main arch wire. That is, in this figure you can see the inner one is the main arch wire. The larger wire that is present in the outer is the auxiliary wires or the auxiliary arches, which is made up of the rectangular stainless steel wire or larger round steel wire. Now these run over the main arch wire and is inserted to the extraoral traction tubes in the first molar bands posteriorly, and it is secured anteriorly with the ligature. So in this figure you can see this is inserted into the extraoral traction tube present in the first molar and on both sides, and in anteriorly ligature wire is used for stabilizing it. Now these are overexpanded in order to achieve desired expansion, and these are also known as expansion arches or jockey arches. These are the other names of the expansion using auxiliary arches, that is jockey arches or expansion arches. And what are the advantages? It is easy to fabricate and insert, and it's also relatively inexpensive because along with the fixed mechanotherapies it only requires one extra arch wire and it produces buccal tipping of the molars. Another method of slow expansion is the NITI expanders, that is the nickel titanium expanders. It was developed by Arnott in 1993. It is also known as titanium expander from the name titanium and nickel. These expansion appliances has the capacity not only to expand the anterior and posterior arch but also to rotate as well as upright and distalize the tooth. It is capable of uniform, slow and continuous force, so the result is more desirable. As the palate expands, the regeneration of the bone matches the rate of expansion, so there is less chance of relapse too. How the expansion with nickel titanium is possible? It is based on the two properties, that is the shape memory and the transition temperature. Now shape memory means that if this appliance is set in a particular shape, then if it is distorted in any other shapes, although it is distorted, they have the tendency to return to the same original shape which was predetermined or pre-planned. And transition temperature, it is a temperature above which the metal wire becomes more stiff and less manipulative, and below it becomes more flexible so that it can be manipulated easily. Now the transition temperature for nickel titanium is about 84 degree Fahrenheit, that is lesser than that of our body temperature. Above 84 degree Fahrenheit, the metal becomes stiff, whereas below 84 degree Fahrenheit, it is more flexible. And as we all know that our mouth is warm, so the temperature in the mouth is greater than that of 84 degree Fahrenheit. So warmth of the patient mouth activates the movement in the thermal nickel titanium energy of the wire towards the appliance programmed shape, and then expansion is produced. That is above the 84 degree Fahrenheit, because of the shape memory, the arch wire returns to its pre-programmed shape. It also consists of the dual temperature sensitive 0.035 inch diameter nickel titanium transpalatal loops. So you can see in this figure, it is a transpalatal loop that is made up of the 0.035 inches, which is present posteriorly, and then anteriorly 0.032 inch stainless steel is present. That forms a finger spring which is designed for lateral expansion of the canines and premolars. So this brings the lateral expansion of canines and premolars. It is formed by the 0.032 inch stainless steel wire, whereas the posterior transpalatal loop is formed by the 0.035 inch thermal activated titanium. Now this appliance comes in 8 different intermolar width that ranges from 26 to 47 millimeter. Now how do we select which size is accurate for which arch? So for the selection of the nickel titanium expander, a size that is 3 millimeter wider than that of the transverse diameter between the first molar should be selected. The nickel titanium expanders are inserted into the lingual sheath, as you can see in this, after cooling them with freeze gel pack that allows them to be easily inserted. Now, after this has been inserted, it is inserted into the mouth where the temperature is greater than that of the 84 degree, and these appliances become rigid and returns to their pre-programmed shape and then brings about the expansion. So this was about the nickel titanium expander. Now, what are the differences between slow and rapid expansion? In slow expansion, the type of expansion is mostly dental, whereas rapid expansion brings about the skeletal expansion. And the rate of expansion is slow in slow expansion, that is about 0.4 to 1.1 millimeter per week, whereas in rapid it is rapid, that is about 0.5 to 1 millimeter per day. And type of tissue reaction, slow expansion it is more physiologic, whereas in rapid expansion it is more traumatic. Force used is milder force, that is 2 to 3 pounds, whereas in rapid expansion greater force is used, about 10 to 20 pounds. The frequency of activation is less in case of the slow expansion as compared to the rapid expansion, in which it is more frequent. Duration required for the expansion is longer in case of slow expansion, whereas for rapid expansion it is short. Now the type of the appliances that can be used for slow expansion is either fixed or removable, whereas for rapid expansion it is mostly fixed appliances. The slow expansion appliances can be used by individuals of any age, whereas rapid expansion has to be used before fusion of the mid-palatal sutures. There is less chance of relapse with slow expansion, so less retention period is required, that is about 1 to 3 months. Whereas in rapid expansion, there is more chances of relapse, so more retention period is required, that is at least 3 to 6 months. The transient diastema appears in case of rapid expansion, whereas they do not appear in slow expansion. So this was about the slow expansion and the rapid expansion. I hope it is clear to everyone now. Thank you for listening.